It's my pleasure to introduce, can you hear me? You can hear me, right? To introduce Joni Haley and Lucy Hodder, two amazing women at the top of their field, and they will be speaking to us about operationalizing privacy and consent for substance use disorders. Joni Haley has been the manager of behavioral health services at the Concord Family Health Center here, as well as Dartmouth residency. She has over 16 years experience, and she's done numerous presentations and worked with us, especially around cultural competence. So we're really excited to have her here today. Lucy Hodder is the UNH Director of Health Law Policy and Practice, Health Law, excuse me, and she is going to assist with the presentation. So with that, I will hand it off to Lucy.
Thank you. And I think we're going to try and speak sitting down. And I wanted to give you a brief overview before handing the real deal over to the real deal Joni, who was the inspiration behind our effort to use an interdisciplinary team to solve a compliance problem at a Concord hospital system around integration. And it was an incredible process, and so we're going to give sort of a summary of sort of as like a case study of what we did and what the problem was. And so the problem stemmed from the amazing work going on in this collaborative, which is the integration of care, and the incredible stories that we just heard of how much progress is happening in that front is really telling as to the impact of this learning collaborative. But the problem at hand was, how does an integrated system, and remember I'm a lawyer, so when I say integrated system, I am thinking integrated by virtue of ownership, or by virtue of ownership and governance even more. So I'm thinking integrated, not just contractually integrated, and certainly not just integrated by virtue of showing up at the same place to do something wonderful together. But how does an integrated system that is integrated by virtue of its structure, as well as by virtue of using a consolidated and unified electronic medical record, comply with the new 42 CFR Part 2 rules? And we know that those now are in effect March 17th. The new rules are in effect. And so how does a system that is integrated in those two ways accommodate the integration of substance use treatment providers and care in a way that models patient-centered care, respect for the patient, observation of their confidentiality needs, all at the same time? So that was the problem we were trying to solve. And I'm going to pass it over to Joni, who really inspired this team to come together and work out solutions.
So many of you were probably here when Sandy Blount was talking about workforce development. And I can remember I was sitting kind of up there, and somebody was, Sandy made the statement that it's better not to hire people with LADAC backgrounds because it presents special challenges in integration. And I remember there was a lot of energy around that statement. And I said, you know what, let's talk about this later, because there are some things that do come with that designation of LADAC or treating substance use disorders, and it's beyond what we can talk about now. And so here we are, 9 months later, and we're talking about it now. I wish Sandy were here to hear, but we'll report back to him about it. So a little bit of the history of Concord Hospital Family Health Center is that we have had somebody who is a LADAC working as one of our integrated behavioral health clinicians for several years now. And sometimes her role is around treating substance use disorders, and sometimes it's doing just the general work of an integrated clinician. And so every now and then she and I would talk and get a little bit nervous about what kinds of special protections need to be in place in the electronic medical record when she is actually talking to somebody about their substance use disorder. And it would make us both a little nervous, and then we would do what any good clinician does, and we would go into a little state of denial. So then we hired at the at the Concord Hospital System, hired an addiction medicine specialist, Molly Rosignol, and she started in the fall of 2015. And then it felt as if, oh, you know, the state of denial when we have somebody who's actually labeled as as an addiction medicine specialist and is documenting in the medical record and is prescribing MAT, then the denial wasn't working so well. So we pulled together this team of people. Lisa Carpenter is here. Molly is not here today, but Ann Brannon, who is a nurse who works with Molly in the addiction medicine program, is here. And so we pulled together this team and started talking about what do we do? What do we do when how do we document this in the electronic medical record and respect the patient and comply with 42 CFR Part 2? So here we have, so as those of you, are people familiar, do we have are there any addiction medicine specialists in the house? Oh, good, we can say whatever we want then. So there is a federal law, and Lucy can talk a little bit more about the history of the federal law, but that gives special protection, in addition to HIPAA, to people who are seeking substance use treatment. And it was from 1987, right?
Prior to that, but last updated in 87 until recently.
So, and those of you who who works in an electronic medical record here? Okay. So one of the wonderful thing is being able to share diagnoses, treatment plan, problem list, medication list, all of that. And yet that is what creates part of the problem. So right now, Concord Hospital is, the outside medical group practices are in one medical record, and then there's a different one for inpatient. That is switching, we're converting to Cerner for outpatient and inpatient within the next 6 to 9 months, I would say. So I'm not sure. So this slide talks about just the goal was to come up with a plan that was patient-centered, that was compliant with federal regulations and state law. So we pulled together the multidisciplinary team that included Lisa Carpenter, who's from risk management, people from the substance use team, both inpatient and outpatient, including Dr. Rosignol. Monica Edgar is a nurse practitioner. We had people there from health and information technology, practice managers were there, and then we had Lucy come in as a consultant to us. So the work was that first we had a lot of conversation about what does it mean to be to provide substance use treatment. If I'm a behavioral health clinician and I'm talking to a patient about substance use, is that considered substance use treatment? And what falls under the Part 2 rules and what does not? So we also took a look at our current practices around confidentiality and privacy, because we do have the integrated behavioral health, those records are integrated. So it's not as if we were blind to the needs to protect privacy. We looked at our forms that we were using, and we updated those forms. Then we talked about a different workflow, and now we're in the process of integrating this into the electronic medical record, and where we are now is in the rollout and the training. So Lucy's going to talk now about the requirements, and I'm going to switch the slide.
Yeah, and I just want to say, I mean, Lisa Carpenter, who's in risk, and Joni were really sort of the inspiration of getting this team together and helping me help them facilitate this ongoing discussion that was really trying to focus on the two things about the rule. The rule is frustrating. It sort of seems to emphasize, in its effort to keep substance use treatment disorder records confidential, it seems to emphasize isolation of that issue and that patient around that confidentiality in order to protect the stigma. which seemed to fly right in the face of this effort to integrate care and really make sure Concord Hospital and its services were focusing on the patient and patient care and making sure there was good communication with treatment providers. And so we were really wanted to be respectful of those two things as this compliance. So we wanted to use the compliance task as a way to really make it work well for the patient and the providers the best we could with a little bit of a cumbersome rule. We knew as an outcome we had to have a couple things because the rules require it. The rules require that there be a notice of privacy policies that meet the Part 2 requirements, that a patient who is receiving substance use treatment services under Part 2 by a Part 2 provider needs to get notice of what their rights are. So we did a lot of talk, and I know that people oftentimes want to just jump right in and get the consent. We talked a lot about, okay, given what Concord Hospital is doing in all its different menus of providing substance use treatment that have sort of been adapted, as Joni described, over time, when really is the Part 2 provider interfacing with the Part 2 patient for Part 2 services? And that we spent a lot of time talking about that and then reorganizing a little bit to make sure we were focusing on that touch point. We knew we had to develop privacy practice notice. We knew we needed compliant consent forms. So that was the key. How could we get the patient to sign off on what we needed to do for care? We knew we needed to have a non-disclosure notice as soon as anybody, and here we have Dr. Rosignol coming in right now. Not to call you out.
Hey, Molly.
She's a key member of our team. How to make sure the non-disclosure notice, we'll talk a little bit about that. That was a really tricky part because anytime someone accesses that record, they need to get the requisite statutory notice. And then we needed to make sure anybody providing qualified service organization services to the Part 2 providers had their agreements updated so there could be a sharing of information. And we knew we were in the middle of the sort of compelling moment was the transition of the hospital to a new EMR and the hopes we could accommodate it there. The other issue was we had the guidance from the new rule about some flexibility around sharing information with treating providers, which we really took to the bank. But we didn't have the final rule until this month. So what we did, I'm still on. So this is a little bit, this is just sort of a scattergram of the basic issues we covered as a multidisciplinary group. And we talked a lot about who is the Part 2 provider. Remember, it's a provider who provides substance use disorder services and holds themselves out as providing. So we dispelled a lot of myths of people who thought they might be at certain points, but actually probably were not subject to the rule at that point. We talked a lot about patient flow. When do these patients come into the system, and who do they touch, and when are they actually getting services, and how do we want to make that work? And then where do they go next? Who are their other treating providers in the system? Who are their third-party entities that we're sharing information with? And really tried to map out from a structural diligent way what the patient flow was and where they were being touched by treating or other third parties. Then we did a lot also about stigma, which is if that's the purpose of the rule, how are we protecting these patients? Where are their issues? Where do the providers see their issues within their own system around stigma? And how can we engage in training and conversation and improve dialogue and use of language around substance use treatment along the way as we're doing this? Then we talked about the non-disclosure warning. How do we do that? If you have treating providers accessing treatment records pursuant to a consent in electronic medical record, how do you get them the disclosure notice? So we'll talk about that in a bit. Then we also try to develop our policies, and we wanted to make them fit the system and the flow that was particular to Concord Hospital's delivery and standard of care. And wanted to adapt them. So we did some drafting and some work on the documents themselves, and we basically tried to collect all the old forms from everywhere. We looked at the EMR capabilities, and we tried to bring in technology to dialogue with the new EMR vendor around that. We talked about workforce education and what was needed. and then how to integrate medical information in a way that was compliant and consistent with the care that the providers wanted to give. So we first identified where the Part 2 teams were in the Concord Hospital system, and which was a critical part in then figuring out how best to accommodate the policy requirements and regulatory requirements of Part 2.
So this was, I think, one of the, I think for many of us, or at least for me, the tendency is to either overreach and, oh my gosh, everybody needs protection and everybody is a Part 2 provider because we all talk to people with substance use disorders, or to kind of go, oh, I don't know, it's too much and I can't think about it. But I was just having a conversation with one of our family medicine physicians who does prescribe Suboxone, and I was saying to him, what do you think? Do you think that your patients need special protection when you are prescribing this medication? And he said, when somebody comes in to see me, they might be talking about diabetes management, their struggles around addiction, about their weight, and about 3 other things. And he said, rarely are people coming in to see me just around the addiction. And so he helped me to understand that, okay, he's prescribing and he's providing services, and yet he is not holding himself out as somebody who is an addiction medicine specialist. And so that was helpful. So I think it takes some teasing out to figure out who the Part 2 providers are and who the Part 2 patients are. And we do have an addiction medicine specialist. As I mentioned, Molly, I mentioned you earlier, and Molly walked in, so good job. And then we also have one clinician I mentioned who has her MLADAC, and another who is under supervision to become an MLADAC. So they are considered Part 2 providers. And then at Concord Hospital, we have substance use services, so a whole department that does inpatient consults and outpatient treatment, assessment and treatment. And so they are considered Part 2 providers.
So we did ask, once we identified the units, and I think did some good talking about what that meant from a care perspective, we asked, is there a disclosure of Part 2 patient records by a Part 2 program provider? And we spent some time on that question. And then we asked why. Why is there a disclosure? Is it for payment? Is it to other treating providers? If so, who are they? Is it for administrative purposes? Is it for referrals and referral follow-up? So as we follow the patients, the clinicians were able to say, this is what works best for their care and this is how it really happens, so that we could figure out how to map the consents based on the patient care that was modeled by the providers themselves. And I think we need to definitely have Lisa and Dr. Rosignol chime in at some point, because I can't tell you how important it was to have that conversation in the context of the risk management, who can segue that conversation with the sort of enterprise risk and push it along with approval of forms and everything else. So then we basically realized this is the flow. We agreed upon a flow for the compliance touch points. One, the note packet of information is going to be given to a patient at a certain time, and it's going to include the notice, the privacy notice with it. Then the consents forms, we needed to make sure the patient had the right consents forms that were compliant at that time, that allowed for communication with the integrated providers. We decided on 2 consent forms, which we'll get into a little bit, because we wanted one for all the treating providers that were integrated in the Concord Hospital system, and then one for third parties who were outside of the usual treatment environment, but they might be entities that were providing inpatient care, or it might be the police departments, or it might be probation officers, or it might be the family court. So we really did try and figure out where is the information going, and create 2 different consent forms. And then we tackled the non-disclosure issue, and then finally the QSO language.
So this is redundant. As Lucy and I have both said, we looked at all the old forms and we revised them. And so one of the things that occurs to me is that it's so, to come and talk to you in a 15 or 25 minute presentation about what we did, when I think about the amount of time that we spent, the number of meetings that we had, the number of emails that went back and forth, I am still waiting for this project to be complete because my emails are my sort of my to-do list, and I can probably get rid of about 15 emails once we're kind of through this. And so it's easy to put up a slide and say, yep, we did all this, and it was a lot of effort on many, many parts.
So let me just, the one added thing was the buprenorphine, and I think I said it right finally. Buprenorphine treatment agreement and informed consent that was also reviewed with risk and collaboration with Dr. Rosignol, just to make sure it incorporated both the way Dr. Rosignol wanted to provide the information to her patients, as well as compliance.
Right. And then one of the things that we really talked a lot about was how do we do the non-disclosure, non-redisclosure language and so one of the things that we came up with, and it was just brilliant, because we were thinking, do we have, for those of you who are familiar with Centricity, I don't know other medical records yet, there's what you call a pop-up, which is when every time you open a chart, then this notice would come up. And I don't know for those of you who work with Centricity, but those absolutely disappear from your brain. It will say, I just did one yesterday, do not talk about Viagra if the patient's girlfriend is present. And so that one actually did not disappear from my brain. That one kind of stuck with me. But sometimes it will say something, patient prefers morning appointments, and then we get on pop-up overload. So it would have complied with sort of the letter of the law, but I was thinking, if this comes up every time we open a chart, people are just, it's going to disappear. So one of the people that we were working with said, what if we did what's called a quick text in Centricity, that there is, that the language, we can add the language whenever there's a document that's created for that says that this information is private, you're not to redisclose it. So that was really not the right language, but something along those lines. So that was one of those brilliant, that will work so well moments. So this is a chart of the patient workflow that in referrals for our substance use disorder treatment come from many different ways. Many times patients are calling, they've heard about Dr. Rosignol, they want to be treated, they're calling on their own. Sometimes they don't know what they're looking for, but they are calling and saying, I need help. Lots of times people, as a result of the SBIRT, will be referred. So patients come in the door many, many different ways. Behavioral health might do the referring, the medical providers might do the referring. So they come in many, many different ways. And then once a patient engages in treatment, that's when they get the packet of forms. And so that is for a patient who, if they are engaging in treatment with a Part 2 provider, that's when they get the packet of forms. So if they're seeing Dr. Rosignol, if they're seeing one of our LADACs, that's when they get the packet of forms. And then one of the consent says, lets patients know that who's allowed to see their documentation. It also lets them know that there is that their problem list and the medication list is available for anybody to see. It's not possible to cloak those within Centricity. So that's something really important for patients to understand. And then as then we are adding the quick text box to those documents that that need to be protected. So I think that again, it feels like way more simple than it is in practice.
And that's by virtue of the talking it through, together. So the key here was the
There we go.
yeah. So yes. So the key here was trying to figure out how are we going to clear out some of the myths of people who think that they are actually providing Part 2 services. So their patients are actually treated and the consents are reviewed carefully with them when they get to the Part 2 provider. And so one of the things we did was we, because of the integrated system and the new rules do allow for consents to identify in general the to whom section for treating providers. So you can say, we are going to be sharing our your substance use treatment records with your treating providers, and we were in an integrated setting. So we could identify the treating providers within the integrated setting and explain that there could be a sharing for purposes of your integrated treatment. And we wanted to be extremely clear to the patients that that was the purpose of their care. They were coming to a place that was taking on integrated treatment as part of their patient-centered care, and that was the reason for their treating providers needing to understand what services they were getting. So that was sort of the key behind the consents. So there's one consent that really identifies that as part of my, as I am a patient of Concord Hospital, and it identifies that they're a patient of this integrated setting. And it explains that as part of my patient-centered care and in order to coordinate aspects of my care, I understand that my treating providers will share private health information about my care and treatment, including my referral, diagnosis, and/or treatment for substance use disorder. So that is very clear to the patient. It goes on to identify the requisite and statutory regulatory notices about it, what their rights are, and who in general the treating providers might be. So it has the specific authorization, does it in I form, and it's meant to be reviewed with the treating provider who is doing the intake with them so that they can go through it. There's also a third-party consent that incorporates any of the additional issues, and we also incorporated special language that Concord Hospital likes to allow for conversations with family members when necessary. So we did incorporate some of the specialized routine sharing of information that is a matter of practice in the Concord Hospital setting for substance use to explain orally or when speak to family members. But the third-party consent really requires under the regulations more specificity. So we had a separate consent that really does have to name the third-party entities that you might be sharing the information with. And that does require sitting down with the patient and identifying it at that point in time. You can't do a blanket consent for third-party entities before you know who they might be. So there's a checkbox for police or probation officers or workers' compensation information or a third-party treatment provider if that needs to be specified. So the contemplation is also that information will go both ways so that the treating providers at Concord Hospital can understand what happens when they are being treated off-site. So that was an important part of what they wanted to capture. And then the quick text is really important, and every EMR system is slightly different, and while they claim to be readily compliant with Part 2, they're not, and I think that was a real issue. It took a long time to even get this on the radar for the EMR vendors of what to do and how to do it. But with the technology folks at the table, we were able to figure out how to bring that non-disclosure, that requisite non-disclosure language into the actual record itself. So a Part 2 provider making a Part 2 record there will be automatically included a non-disclosure. So if another treating provider accesses that information, it's there. So that went along with it.
And we are thankfully in conversation with the folks at Cerner who will be providing our new EMR. And what we think is going to happen is that there will be notes that are specific to substance use treatment that will have this language on the top of each document. So that's the latest thinking around that. So, boy, this does not want to go.
I think it's the other.
There we go. So the next steps, we are in the process of creating a training plan for the Part 2 providers. That's easy because there aren't that many of them. But also, what if I'm a provider in urology and I come upon one of these documents? What do I do? So to let people know about that. We are constantly working on just what our workflows are, coordination of care, all of those kinds of issues, and then create a training on stigma. I think that's an ongoing conversation. I know that Molly's very, very involved in that. Molly and Ann both are very involved in that. And so it's, again, another thing, it's, like a little bullet on a presentation that is probably, if we had a doctoral student or an MSN student, it would be great to have somebody really create a whole system of trainings around that. I saw Martha Bradley, and so we've also been working around our experts. So, this, as all of us, we're thinking a lot about this in our practices. And then, we have the IDN that Felicity was talking about that we're all thinking about. And so how is this going to flow with our, we're part of the Region 2 IDN, how is this going to work with that? And then Lucy had to put this last one in, so I'll let her say this one.
So there's the ongoing, continuing assessing the regulatory guidance, because we know there's a new administration, and we're just trying to monitor where they're going. And there's a lot of little details that we were cognizant of, which is, how long can it be in effect? How is it revoked? A number of the details, especially with the interpretation of the new rules, that we did grapple with along the way. So we're giving you the highlights as opposed to a lot of the sidetrack issues we had to pin down before we came up with the best solution. And
one more thing that we haven't yet come across, and when we do, then we'll really scramble, but we're thinking about it ahead of time, is what if somebody actually refuses, does not want their notes integrated into the electronic medical record? Then what do we do with that? Because it's not ethical to not treat. So we have thoughts about doing a paper chart, thoughts about doing having a name that's not, that would be John Doe. So we're thinking a little bit about that. What do we do with that? But that's not how I want to end, because that one is one that now I'm going to be up again at night thinking of this as...
right. Well, I didn't know whether Lisa or Molly wanted to chime in about the process or next steps or the implementation.
I would just say that the last point is what keeps me up at night as a risk person. I think that I really struggled at the beginning of my education around Part 2 because as I understood the rule, the goal was to cloak these things, to cloak all the records. And by cloaking, that means making it so that literally no one else can see it, which just totally flies in the face of integrated care. We went to this fancy schmancy new, Cerner product people that were putting in and paid I don't know how many millions for it, and said, so what are y'all doing around the country with Part 2? And they don't have an answer. And so, you just kind of think, if these folks don't have an answer for how to make this work and how to be compliant, I'm not sure how we're going to figure it out. So all we can do is rely on the fact that if you can get patient consent, then life is good again, and you can, continue to go about providing, good integrated care for people. So it's just, I think that's the place you have to sort of get yourself to, is to understand that we're not really complying with the true, I think, goal of Part 2, which is to cloak all of these things. What we're complying with is the ability in the regs to do an end run by getting patient consent. So at the very beginning, we really had to kind of address that question of what kind of numbers are we talking about, and at the end of the day, we were pretty well convinced that the number of people who would not consent to an integrated model would be very, very small. So assuming that's true, I think we'll be able to manage it. If those numbers were to grow, I think we'd have to cry uncle, because these EMRs just simply don't allow for that kind of cloaking.
So it looks like we have a few questions in the back.
Hi, I'm Bill Ryder from the Mental Health Center of Greater Manchester, and my question is, if so few people object to it, the EMRs can't adapt to it, how many years will it be down the road before the law gets changed yet again to just make it seamless, no matter what ails you? It's one consent and one uniform system of confidentiality.
I can't predict that. We just went through rulemaking on this, and that was the suggestion of a lot of commentators to make it consistent with HIPAA, and that was rejected by SAMHSA. I think their effort to make it seamless for treating providers was their first step. So I think it's an ongoing push. It's a balance. I do think that Lisa was very accurate in saying we were trying to make the balance. We did also consider very intently the issue of stigma around substance use, and decided that we could solve that problem better by compliance, education, discussion, really figuring out where were there bumps around the stigma, where was it going wrong for a patient. And that is something that, if you look throughout our crazy healthcare regulations around fraud and abuse and all those kind of things, the government does end up at a place where they do emphasize education and treatment to remedy some of the wrongs that go on. And so I think we were trying to get one step ahead of them and try and incorporate that as part of a solution, because I don't see a time and place clearly in the near future where that's going to happen. But I hopeful.
Just as a follow-up comment, it just seems to me that there's a lot of things in our healthcare system that that get hung on to like this, because you have so many people, such a high percentage of people who consent. They're basically voting at that moment in time that they are very fine with having their health care information integrated. And it's like the same for prior authorization. Something like 93 or 94% of the time, the payer agrees with what the doctor's office is recommending. And yet, you have to have all these people just lined up to make all these connections to have some element of care go to the patient. And all of this takes a lot of time, a lot of cost, and puts a lot of people at financial risk that's, in my view, totally unnecessary. And I think that we need to really try to keep pushing very hard to root these things out, because it's just going to make everything better for everybody, families, patients, providers.
I think those are some good comments. We can probably take one more question.
In that same vein, did you consider at all, and of course without considering advice, did you consider putting that consent on every patient form, so that if they, because to me that's part of non-stigma, is if you make it part of everything, then if you choose to do this, if you don't choose to do this, obviously the third party would have to be a separate thing when and if it came up, but you're nodding, so I'm assuming that you thought about it.
We did. We thought about it, and now I can't remember why we rejected it, but it was definitely, like I said, that idea that everybody gets this special layer of protection, meaning nobody really does. That the pop-up comes up on every single chart saying, and that we say to every single patient, if you do seek treatment for substance use disorder, it will be integrated into the chart. And then we decided that actually did not meet the.
Yeah, that could happen, and I think with maybe a smaller institution or a Part 2 provider, that might be absolutely fine. But we felt like at the end of the day, that was such a universal application of it to everybody that it was undermining, our effort to deal with the rule's real purpose, which is to deal with the stigma of these patients. So I think the clinicians basically felt if we had the pop-up on every single record, it would be completely ignored, or And if we had it on every patient record, no one would really take the time to go through and say, hey, this is substance use, now you're specially protected, et cetera. So it was both for sort of regulatory and you know, you could go either way, I would think. I think we came out with the right decision for the treatment providers at Concord Hospital.
I would just add, Lucy, that I think that and one of the touch points we had, the reason we went with the idea of the text message that's actually on the document itself is that if you had a patient who someone was seeing that really had nothing to do with substance use disorder, that provider or those clinicians could potentially work with that patient and not really be aware of that treatment in a good way. I mean, if it had medications, they'd see those and they'd see it on the problem list. But the documents themselves, they wouldn't really have any reason to go into them or whatever. So the only reason that they would be aware of those documents is if they actually tried to open one.
And I guess I'm thinking more of the patient consent form.
Right.
Being sort of the general, here's your consent, you join the practice or you come here, sign this consent. And then obviously being more specific with either the third-party disclosure or the pop-up, the text, and making that very specific to whichever individual patient. But you don't have to do all or none. I guess you could pick one or and or.
You could do it that way if it worked for your group.
We talked about it. I think the other thing we came to is that we really felt that those patients for whom this extra protection was afforded sort of deserved that conversation in a very directed way. And to sort of splash it across everybody's consent forms really sort of minimized the value of that extra protection for that patient. So by having those packets put together just for those patients, just with the extra protection that they should be aware of, I think we thought was honored that.
Right,
more.
and because there's a notice, there's a non-disclosure, there's the special part of the consent form. And also with the patient flow, the substance use disorder patients, the referral patterns for their care, might be slightly different in terms of where they go next and how to get that. So for those several reasons, I think we.
So you're all going to have an opportunity to network now and actually ask more questions, and maybe this is an opportunity to bring you back and further down the road and see how it's going.
Right.
What happened?
Post Cerner.
Yes, post.
Right.
So if you have a blue dot in your behavioral health, can you raise your hand? All right. If you have a red dot in your primary care, raise your hand and look around the room. Okay. If you have a yellow dot in your payer, all right, and then green dot your other. So that could be a lot of people, right? And you might be multi-dot. So what we're hoping now is we've heard you want time to network, and that you'll go meet someone new and you'll make those connections. Maybe you heard someone here and you have an interest in their materials. Go on and ask them a question, have a brief break, go to the bathroom, and we'll be back here at 10:30.